jugular venous pressure has gone up. I'm not going to show other changes, just I will show that this whole pattern has gone up. Is that right? If simply this pattern go up, we say there is raised jugular venous pressure, and due to this pressure, neck veins will look distended. Veins will be obvious as distended waves. So we will also say that there is jugular venous distension, right? And plateau, we call it plateau of this as raised due to pressure. Now we come to what waveform will be changed. We said there will be sharp X descent and there will be loss of Y descent. Loss of Y descent is more strongly associated with it. And I want my students to understand very clearly why Y descent is lost, because it's a very, very sensitive sign. You may not observe very well here, but with central venous straight line tracing or right atrial pressure tracing, you can see it very clearly that Y descent is blunted or reduced or lost. And in constrictive pericarditis, when you compare the patient with cardiac tamponade with the patient of constrictive pericarditis, one of the classical difference in the Y. In case of cardiac tamponade, Y descent become blunted. I will explain why. And in case of constrictive pericarditis, Y descent become very rapid and suddenly abruptly stop. That I will explain later. Now let me explain why there is loss of Y descent. Right? Let me explain. Actually, why the original Y descent was there? I told you in the beginning. Y descent occur when which valve open? What is this valve opening? Tricuspid. When tricuspid valve open and in early diastole pressure is very low, so blood will rapidly enter here and it will come down and Y descent will come. Now you imagine if there is cardiac tamponade, then this will be pressing on the chambers, and if it is pressing on the chamber, now you imagine if the fluid is pressing here, you are understanding? Do you think when this valve will open, it will be very low pressure chamber? No. Again listen. Okay, just imagine here. If there were tamponade fluid here and pressing it too much and keeping it compressed, when tricuspid valve will open, can blood rapidly fall down? No. You seem intelligent. Let me repeat it. Listen carefully. Normally what happens that when this ventricle chamber open, tricuspid valve open, right, it expand into, in diastole, it expand into all directions. And when pressure is low, this blood will go down. That is early diastolic filling. Early diastolic filling. And when this blood is going and early diastolic filling is occurring, right, Y descent come. Is it clear to everyone? Now you imagine here is tamponade here. If tamponade is here, then this unfortunate right ventricle is pressed. It is sort of compression. It has some sort of diastolic compression. Later on I will tell you this compression, diastolic compression, also is seen on the echocardiography and help in diagnosis. When this is compressing the chamber, from the very beginning of diastole, there will be high pressure here. From the very beginning of diastole, even in early diastole of the ventricle, pressure is high because there is high intrapericardial pressure compressing it. When pressure is high, can this column fall even if this open? So it will not fall. So can you find a Y descent? No. So this Y descent will not be there. Now in this diagram, normal Y descent is shown here. So this Y descent will not be seen. You will find that after the V wave, this will move like that. Go directly to it cannot descend down. So Y descent is lost here. You understand it? This Y descent, which was supposed to be there, it is not there. and V wave directly goes to the A wave, because still ventricle will be filled to some extent but under higher pressure. So because pressure does not fall, Y descent is not there. Am I clear? So again, in this case, again this is atrial contraction, valve closure, X descent, atrial relaxation, venous accumulation, you are getting it, and then again valve, tricuspid valve opening and Y descent. But can this Y descent can blood go? No. So pressure will remain again like that. So this is what is lost. Am I clear to everyone? Yes, sir. Or only teaching myself enthusiastically? So the classical feature is loss of Y descent in patient with cardiac tamponade. Now good doctor will say, oh, I know there is jugular venous distension and there is jugular venous pressure raised. A very good doctor, right, who has practiced himself not only to look at the pressure, because there are doctors around who cannot find where is the jugular venous, where to look the jugular venous pressure. But if you are good, you can find the pressure, and one day you will become so good, you may know how to look at the pulse pattern, right? And in this case, normally you have two pulse pattern. A, C is usually not visible here. So you find it goes up, down, up, down. The second down is lost, right? So this can be, so first mechanism I told you, number one, jugular JVP, what are the changes? Number one, plateau goes up, total pressure goes up. Number two, the loss of Y descent. Am I clear? There's no question. But there is no problem with the X descent. Why the X descent is there? Let me repeat. Atria contracted, I'm going to normal. What is this? Now atria start relaxing. When atria is relaxing, here the valve close, and now as soon as this valve close, I'm talking about now X descent, how it is produced. This valve is closed, but because atria is still relaxing, blood column is still coming down. So what is this? X descent. Is that right? Now this X descent, now listen carefully, this even becomes sharp. Sharp mean that, yes, there is X descent, this is, right? Rather than it becoming like this, it become more sharp and even deeper. Is that right? Why? Because there is high pressure of blood here, which eventually fill it while it is relaxing. Because pressure in the jugular system has gone up. Am I clear? But really what you need to understand and remember, only two things in jugular venous JVP. Number one, patient with tamponade, jugular venous pressure is going up. And number two, if you're very good, you will find Y descent is lost. Am I clear? X descent, this small thing may be seen in the tracings of central venous pressure, but cannot be clinically detected. It's very difficult. Am I clear? So this was about the jugular venous, and jugular venous pressure changes are the most sensitive sign about what? Cardiac tamponade. And now we come to the blood pressure. Yes. Okay, before that we talk about the muffled heart sound. There's not much explanation for that. It's very easy to understand that if a lot of fluid is there and you are putting this chest wall and then put the stethoscope, heart is far away from your stethoscope, diaphragm or bell, and you cannot hear the heart sounds very well, right? And secondly, when heart is compressed, it's really not beating very hardly and not producing so much sound. Number one, it is less soundy, and number two, it is away from our hearing mechanism. So heart sounds may be soft or muffled or may disappear. And of course, at that time, if you try to find the apex beat, because there's a lot of fluid between the apex of the left ventricle and your chest wall, right, beat may not be transmitted well. So there will be loss of apex beat or very weakened apex beat. Am I clear? So this is done with the triangle, this part of triangle. Now we have to talk about this part of triangle. That there is falling blood pressure and eventually pulses, paradoxus appear. Rather, I will discuss in detail pulses, paradoxus later. Right now, I will tell you why the blood pressure falls. It's very easy to understand that what really happens in this patient, patient with cardiac tamponade, let me draw other diagram to explain how the systemic arterial blood pressure drops. Systemic arterial blood pressure drops. It's about the basic hemodynamics. I will draw only the left heart and the tamponade diagram, right? Okay. This is cardiac pericardial fluid. Now, this is pressing here and it is also pressing here. And as I told you, if pressure here is more than the filling pressures, of course here is the systemic venous pressure coming and here is pulmonary venous pressure coming, because here the blood which is returning from the lungs. Is that right? Now, if pressures here are higher, of course venous return cannot be maintained very well, right? Well, so what really happens that due to higher diastolic pressures, because when ventricles relax, we call it diastolic pressure, and diastolic pressure should be very low so that blood can come and accumulate here and later on it can pump out. But what really happens, because it is being squeezed from outside or strangulated from outside, so pressure inside the ventricle even during what? Diastole is higher. Because pressure is higher, so venous return becomes slow. So we can say that sequence of events is, number one, as there is increased pericardial pressure. When there is increased intrapericardial pressure, that will lead to, decreased ventricular filling, and that will lead to decreased end diastolic volume. When ventricular filling will become less, at the end of the diastole, total volume here will be less. And if end diastolic volume is less, of course, end diastolic pressure is also less. And secondly, when there is underfilling of it, can it stretch the myocardium? If, okay, leave it, end diastolic volume is less, and when end diastolic volume is less, can it stretch the myocardium well? No. Now, according to Frank-Starling law, all of you know, within physiological limit, more you stretch the myocardium, more it contract. Less you stretch, less it contract. It's very simple. It's like elastic, women know very well, right? So what happened, that's like elastic within physiological limit. More you stretch, more it snaps back. So heart is something like that, right? So Frank-Starling laws, when you are underfilling it, it is understretching. So what will happen? End diastolic volume is less, so that will end up into decreased myocardial stretch. When myocardial stretch becomes less, there is decreased myocardial contractility. And when contractility is less, then what will happen to stroke volume? Stroke volume is less. And when stroke volume is less, then cardiac output is less, and that will lead to drop in systolic blood pressure, right? So as in a patient with cardiac tamponade, more and more fluid accumulate and more intrapericardial pressure goes up, right? That will lead to keep on reducing the ventricular filling, and that will keep on reducing end diastolic volume, and myocardial stretch and contractility will become less, stroke volume will become less, and eventually that will translate into dropping blood pressure. Am I clear to everyone? Now, of course, when your blood pressure drops significantly, what happens? Sympathetic overflow occur, compensatory mechanism come into action, and you develop tachycardia. Is that true or not? So actually, there will be tachycardia, even due to anxiety. Another reason, patient will develop tachypnea also, and even dyspnea. So tachypnea mean increased respiratory rate. Tachypnea and tachycardia and sort of anxious look, cold clammy hands, cold nose or peripheral parts of the body, these are features of shock. You are getting it? tachycardia is very important. Tachycardia is not, of course, specific for tamponade. Tachycardia occurs in so many conditions, but there is something, a very important thing, write it down. If there is no tachycardia, there is no tamponade, except 2 or 3 conditions. If there is no tachycardia, patient doesn't have tamponade. If JVP is not distented, your diagnosis is wrong, it is not tamponade. Am I clear? Why? The reason being, when there is tamponade, hemodynamic disturbance is so grave that sympathetic overflow should occur and compensatory mechanisms should come into play and tachycardia must be there. So if there is no tachycardia, there is no tamponade except 2 or 3 exceptions. For example, those patients of tamponade who have pleural pericardial effusion due to mixed edema, due to hypothyroidism. Of course, a patient with hypothyroidism has heart rate of 50. He will also get little sympathetic overflow, his heart rate will become 70, but it will look like normal. There is no tachycardia. Another exception you should remember. I'm stressing again, if there is no tachycardia, there is no tamponade. Right? If there is no jugular venous changes, there is no tamponade. But there are few conditions. A very good doctor will be alert that sometimes there may be patient with tamponade but no tachycardia. Classical example is patient of tamponade with mixed edema. Another classical example is tamponade with uremia. You know, uremia also produces bradycardia and heart blocks. Good doctor should be knowing it, Dr. Iftihar, right? So what happens if a patient is transferred from nephrology ward, is uremic and having a sort of pericardial effusion and even tamponade, some features of hemodynamic instability are there even clinically or echocardiographically, but tachycardia may not be there. Is that right? Third, of course, any patient due to any other reason who is on beta blockers, right? And then classical cause, patient is unfortunately just about to die. In very terminal cases, when patient reach to you very late, he is all unfortunately with very grave tamponade, patient may still have, unfortunately, he is in bradycardia, not tachycardia. So I told you 4 conditions. First, the basic rule. Basic principle is what? Basic principle is that if no tachycardia, no tamponade. No tachycardia, no tamponade. But 4 conditions a very good doctor will keep in mind. Either patient has tamponade due to mixed edema, tachycardia may not be there, or with uremia, tachycardia may not be there, or due to some other reason, if patient is on some beta blocker type drug, tachycardia may not be there, and if unfortunately patient is in very terminal stage, and very terminal stage produces cardiosuppressants and tachycardia doesn't occur. Am I clear? What is left here to discuss? The paradoxical pulse. It is so important. It's a very, very important clue to the cardiac tamponade. I will discuss that into detail. But before I leave this part of the lecture, I would say the classical Beck's triangle. Beck's triad. This classical Beck triad of signs and symptoms, or you can say this clinical situation, classically is seen in acute tamponade in which there is rapid deterioration in hemodynamic parameters. But if it is chronic tamponade, very slowly and gradually developing large effusion and very gradually, you can say, strangulating the neck with love. It happens sometimes, right? If that kind of situation is there, features of Beck triangle may not be very pronounced, but features like heart failure may be there. Features like heart failure may be there, right? For example, now, again listen. Here is your heart, and it is very gradually developing sort of very long-term mild tamponade, right? It may have some features like cardiac failure. It is right. Now these are the pressures, and very slow, very mild pressures, mildly disturbing compressing the heart. In this case, of course, when there is more pressure on the right side for a long time, jugular venous pulse will be chronically elevated, even central venous pressure will be elevated, and then hepatic veins can't drain well, and that will lead to, again, what will happen? Can blood drain from portal system to this? No. So because it is being compressed for a long time, right? So due to chronic elevation of central venous pressures, back pressure to the, what is this thing? Lever may lead to hepatomegaly, may lead to ascites, even because the hydrostatic pressure elevated in all capillaries in the body may lead to systemic edema, mild. With that, if left side is unable to receive the blood, back pressure to the lungs will lead to, yes, pulse. It will really not lead to frank pulmonary edema, will not be there, right? But we can say that there will be congestion in the vessels in the lungs, right? And that will eventually translate to some degree of dyspnea. Remember, dyspnea is a very important feature of tamponade. So there may be dyspnea, cough, orthopnea. Orthopnea is dyspnea worsening on lying, just lying up or down? Lying spine, okay, that's right. Lying spine, okay. So there may be sort of features of biventricular failure. From left side, feature may be just like cough or dyspnea or orthopnea. With forward failure, there may be fatigability, weakness. And here, there may be hepatosplenomegaly with ascites with little generalized edema. But this type of situation is seen in subacute or chronic tamponade. So we can say in a very acute tamponade, you will find the classical Beck's triangle. But in subacute or chronic tamponade, there may be some mild features of Beck's triangle, right? With that, there will be some features like heart failure. Am I clear? Now, in these patients who come with the tamponade, what other clinical features can be appreciated? What other clinical features may be there? As I have discussed, up to now only I talked about those clinical features which develop due to hemodynamic instability. But of course, there may be clinical features due to underlying cause. For example, if someone developed tamponade due to tuberculosis, he may have clinical features of tuberculosis also. Weight loss or night sweats, or night sweats remind me something. Yes, night sweats, low grade fever, anorexia, you are getting it. Or if he developed, let's suppose, tamponade due to uremia, he may have some features, of course, other features related with renal failure. So what I'm saying, or he developed this due to acute pericarditis due to what is this? SLE. So the features of SLE will be there, systemic lupus. So what I'm trying to say, if a patient comes with tamponade, first of all, to be sure the patient really has tamponade or not, you have to demonstrate clinically that hemodynamic system is undergoing destabilization with rising JVP, falling blood pressure and muffled heart sound. And if it is chronic, then features like heart failure should be there. But with that, whatever is the real underlying cause of pericardial effusion, features of that may be there, right? And then many of these patients have developed tamponade due to acute pericarditis. So features of acute pericarditis may also be there. So we can say the total features which should be may be present in these patients. Number one category is features due to hemodynamic instability, which include the Beck's triangle, and in chronic cases failure, features like failure. Secondly, signs and symptoms of underlying cause of pericarditis. Underlying cause of pericarditis, because first there have to be a disease produced pericarditis, like first disease is, for example, tuberculosis, which lead to pericarditis in some patient, and in some more patient with tuberculous pericarditis, tuberculous effusion develop, and in some more patient effusion goes into tamponade. So disease may be like this, that primary cause, then it may lead to pericarditis, that may lead to pleural pericardial effusion, and some of these patients develop tamponade. So features of tamponade, of course features related to the pleural effusion may also be there, right? And it's not pleural, pericardial effusion, please correct me if I'm wrong. And then features of acute pericarditis may be there, and features of underlying cause. Now features of acute pericarditis, as I told you, hemodynamic instability features, then clinical features related with underlying cause, and underlying cause should be signs and symptoms of underlying cause, etiology of acute pericarditis, and features of acute pericarditis may be present in some of these patients, right? What will be the features of underlying cause? I told you, as it depends on really underlying cause, right? If it is renal failure, of course, those features will be there. If it is tuberculosis, those features will be there. If there is mixed edema, then hypothyroidism features will be there. Then come features of acute pericarditis, like chest pain, right? Features of chest pain may be there. I've discussed features of acute pericarditis in previous lectures into detail, right? That there may be chest pain, but you should not forget that tuberculous or neoplastic or uremic acute pericarditis may be painless. Then pericardial rub can be there. Most of the time, as pericardial effusion enlarges, pericardial rub disappear, but in some patients it may be still there, right? Then there may be ECG changes of acute pericarditis, which I will discuss later, that in acute pericarditis there is ST segment elevation and PR segment depression, right, which we have already discussed in previous lecture. And then final feature of acute pericarditis with effusion, there's a feature called Ewart sign. That also we discussed in the previous lecture, that in the left lung, right, sometimes pericardial effusion compresses so much that lower part of the lung, left lung, become consolidated, collapse, right? And then this sound which is coming, bronchial sound, right, it cannot divide into smaller pockets and become vesicular, so it remains bronchial. You are understanding? Again, in some cases with the pericardial effusion, right, it may compress the left side of the basal part of the lung, and this part of the lung, when it becomes consolidated, right, then bronchial sounds which are coming through bronchial tree cannot divide into this small area and convert into vesicular nature. So bronchial sound can be heard here, of course back of the chest at the angle of the scapula, and there can be dullness to percussion. Is that right? This is called Ewart sign. So what did I say? That when we are talking about clinical presentation, we talk about clinical features related with hemodynamic instability. Clinical features may be pointing towards the acute pericarditis, and there may be clinical feature pointing towards the cause of acute pericarditis. Is that right? A very good doctor has the responsibility to find all those things, right? Then I will go into detail of Pulsus paradoxus. As I told you, with falling blood pressure, Pulsus paradoxus is a very important clue to this condition, right? Now, what is Pulsus paradoxus? Before really I go to the Pulsus paradoxus, I want to explain a very important physiological concept related with the respiratory cycle and arterial blood pressure. And then I will tell what is Pulsus paradoxus, right? Now, let me tell you that I'll draw it here. Blood pressure. You know, blood pressure, if you put a manometer in my brachial artery, I hope this is brachial or femoral? Brachial, okay. So brachial artery, sometimes I forget anatomy, right? So a brachial artery, if you put a manometer, when heart contract, pressure goes up, that is systolic, and when heart is relaxing, when left ventricle is relaxing, pressure goes down, it is called diastolic blood pressure. So let's suppose my blood pressure is ideal, even though I don't have many things ideal, but I'm happy with my life still. So what is there? That your blood pressure measurement the systemic arterial blood pressure, it fluctuates like this. It goes from 80 to 120 down. Now what is this? This is systolic blood pressure, then come diastolic, then systolic, then diastolic, then systolic, then diastolic, right? You understand it very clearly, everyone understand. Now, actually during respiratory cycle, there is fluctuation in systolic blood pressure. You must be knowing systolic blood pressure mainly depend on cardiac output. If left ventricle is producing more cardiac output, systolic blood pressure will go up. For example, if my left heart more strongly contract, right, systolic blood pressure may go up, right? Or if my left heart contract very weak, then systolic blood pressure will be less than normal. So what I'm saying, the systolic blood pressure depend on the performance of the left ventricle. Systolic arterial blood pressure. This is your left ventricle, right? This is the valve. Now let me tell you what really happens during respiratory cycle. If there are changes, basic concept, if there are changes in left ventricular output, there will be changes in which pressure? Systolic blood pressure. Is that clear? If there are changes in cardiac output of left ventricle, there will be changes in systolic blood pressure. Now we see during respiratory cycle what really happens. This is your chest, right? Diaphragm. Here lies your right heart. And let's suppose here is your left heart, right? Okay, let me make the septum more clearly. This is left heart, okay. This is your right heart, right? Now, listen, actually, normally pericardium which is around it is there, it is not